Hello, everyone, and welcome to Mending Kids Virtual Educational Symposium on Critical Congenital Heart Disease at Birth, How to Diagnose, Stabilize, and Treat. I'd like to say a few words. I'm Isabel Fox. I'm the Executive Director of Mending Kids. Mending Kids is a nonprofit that provides critical surgical care to children around the world. And we have been partnering with the Jakaya Kikwete Cardiac Center in Tanzania for over 5 years. And as a way of staying connected and as a way of providing an exchange of knowledge, we are promoting this symposium today for our colleagues in Africa. The symposium was created by Dr. Evan Zahn, who's the Director of Congenital Heart Programs at Cedars-Sinai Medical Center in Los Angeles, and Dr. Darren Berman, who's the co-director of cardiac catheterization and interventional therapies at Nationwide Children's Hospital in Columbus, Ohio. But before we begin, I'd like to mention that any questions you have of the doctors who will be presenting today should be posted in the chat, and we will answer them at the end. And that this symposium was made possible through an Edwards Lifesciences Foundation grant, and again in collaboration with the Jakaya Kikwete Cardiac Institute. I'd like to introduce Professor Mohabit Janabi, who is the director of the Institute, so that he can say a few words on behalf of our African colleagues. Thank you very much.
Yeah, thank you very much, Isabel, for the introduction. My name is Janabi. I'm a cardiologist and CEO of JKCI. Good evening to everyone. Good afternoon and good morning. It depends which part of the world you are. Everyone, if you allow me, because you're coming from different parts of the world, Tanzania is the largest country in East Africa with a population of almost 60 million, 44% of whom are less than 15 years, making it one of the youngest population in the world. Although the median age is only 17 years, life expectancy is 63 years. Our birth rate, which is related to today's talk, is about 34 in 1,000, stands at 34 in 1,000. A little bit on our partnership with Mending Kids started way back in 2016 when I met Madame Isabel Fox. Then she was a coordinator of the mission and currently the CEO of Mending Kids International. I saw our mission is and was same to what we discussed with her, to advance medical expertise and care in our country through training and education of local medical personnel, from the nurses, technicians, doctors, bioengineers, and everyone involved in the care of the kids. Through this model, it has improved healthcare and medical autonomy by investing knowledge, skills, and time. I'm just imagining this time of COVID when we had no missions, but the knowledge we got through Mending Kids and others enable us to continue to operate. You could have done the other way, the old-fashioned, just send dollars from abroad. It could have not helped us very much. So I'm very grateful to that. So the ball started rolling. It gave the opportunity for these Tanzanian children with their congenital conditions to be repaired, gave them hope of leading a healthy life and happy and be able to attend schools in the future. Since its inception, our partnership with Mending Kids, they've visited our country 5 times and mended more than 104 kids through cath lab procedures, 78 open heart surgeries with a death rate of 9, making it 5%, which happens in any surgery which is performed, but aided in diagnosing more than 500 kids to receive a correct treatment. So with those few remarks, really this continued education, COVID-19 didn't come with everything bad. We created Zoom and webinar meetings, which we continue to educate us. So I look forward for a healthy and fruitful discussion. Thank you all.
Thank you so much, Dr. Janabi. Hello, everybody. Good morning, good evening, good afternoon, depending on where you are. My name is Evan Zahn. I'm a pediatric interventional cardiologist and have had the great pleasure and honor of going over to Dar es Salaam and working at JKCI with Dr. Janabi, Dr. Naiz for the past 5 years. And I must say, of all the things that I'm a bit upset about during this COVID pandemic, as we all are, one of the things that hurts the most is not being able to go over and visit our family, really, over in Dar es Salaam and work with the wonderful nurses and doctors there and try and help some of the kids there from all over East Africa, because we've treated children there on our missions, not only from Tanzania, but other countries as well. So we're really happy to see all the representation that we have just in this meeting from various parts of the African continent. I just want to take a minute to introduce my co-moderator and co-host for the meeting today, Dr. Darren Berman. Darren is truly one of the up-and-coming superstars of the field of intervention. And I'm really happy that he was able to join us, and Darren hopes to soon be participating in missions with Mending Kids as well. So I'm going to hand it over to you, Darren, and maybe you can get us going with the meeting.
Thank you, Dr. Zahn. I too would like to say how excited I am for today's first teaching symposium, and was quite moved by Dr. Janabi's words of how long of a history there's been with Mending Kids. And I too am excited to start my journey and work with Mending Kids and the group in Tanzania. But to kick us off, I'm going to introduce our first speaker. It's Dr. Kaitlin L'Italien. She is one of my colleagues here as a pediatric cardiologist in our heart center at Nationwide Children's Hospital, and one of her main focuses is on inpatient care. And she's going to talk to us about newborn screening for complex congenital heart disease. So Dr. L'Italien, if you want to share your screen.
Thanks, Darren. I'm in the process of sharing the screen. Let me know when you can see.
Yeah, we'll see you.
Okay, here we come. So a little bit of a delay. Here we go. Okay.
Perfect, Kaitlin,
All right.
It's up now.
Wonderful. Thank you so much. All right. So I have the pleasure of speaking to you all today about the screening for critical congenital heart disease. Objectives of this talk today involve understanding the limits of neonatal physical exams and the ways in which pulse-ox screening can help detect critical congenital heart disease. To describe the overall sensitivity and specificity of critical congenital heart disease screening, as well as variations between types of congenital heart disease and limitations of the test. And finally, to demonstrate how to perform the critical congenital heart disease screening and how to manage a failed screen. So we begin with a clinical case, the well baby. You're covering the well baby nursery for your family medicine group. Baby Jonah was born to a 31-year-old G4P4 mom via normal spontaneous vaginal delivery. Mom's doing well and requests early discharge. At 22 hours of life, Jonah's heart rate, respiratory rate, blood pressure, and exam are all within normal limits, so you feel comfortable with okaying him for discharge. Tragically, 4 days later, the ER calls. Jonah has just arrived in extremis. His O2 sats are in the 50s, blood gas reveals extremely low partial pressure of oxygen and significant acidosis. A bedside echocardiogram performed reveals critical pulmonary stenosis. While obtaining access to give prostaglandins, Jonah becomes unstable and coded. Resuscitation attempts were unsuccessful. You can't stop thinking of the last time you saw baby Jonah. He appeared so well. How could you miss critical congenital heart disease? Was there some other way to tell that Jonah was born with a critical heart defect? And the answer is yes. The critical congenital heart disease newborn screen is a relatively simple procedure using pulse oximetry that has the potential to detect defects that would otherwise be missed with standard exams alone. So let's begin with a few definitions. Obviously, congenital heart disease, which we all know well, any congenital heart malformation that the infant is born with, versus critical congenital heart disease. Critical congenital heart disease is congenital heart disease that requires surgery or cath intervention within the first year of life. A particularly extreme subset of that would be ductal-dependent critical congenital heart disease, in which the infants would require intervention typically within the neonatal period. So isn't a good physical exam enough to identify most critical congenital heart disease? And the answer is no. Well, it does identify many, many cases, but there are some that will be missed. The reasons primarily because it's difficult to detect hypoxemia in a newborn, given the fluctuations in normal oxygen saturations within the first day or two of life. If exam is completed before their patent ductus arteriosus closes, the signs and symptoms of a ductal-dependent heart lesion may be masked. And up to 5% of normal newborns may have transient murmurs, whereas many with critical congenital heart disease may not have an appreciable murmur at all. In 2008, a study from the UK reported that up to 25 patients with critical congenital heart disease were diagnosed after discharge. Therefore, they were discharged without knowing that this child suffered from critical congenital heart disease. In 2009, a study from Sweden looking at 32,000 infants showed that those who were screened with for critical congenital heart disease with pulse oximetry, they only missed 8% of those cases versus 28% of the babies who did not undergo pulse oximetry screening. In that same study, they also reported that 44 patients with detransposition of the great arteries were diagnosed after hospital discharge versus none that underwent pulse oximetry screening. So why pulse oximetry? It's not invasive, it's inexpensive, safe, reliable, and there's the potential to detect hypoxemia in a patient that is not visibly cyanotic. This is a really important point and one that I really wanted to emphasize. I think in my experience working with many trainees, there is a fixation on cyanosis and being able to, see cyanosis in an infant. And there are so many things that affect the
I'm not sure if we've lost Kaitlin, but I think we should probably come back to her or the presentation.
Yeah, I'm communicating with her now and seeing if she can get reconnected quickly here. It's unclear what happened.
Let's give it just a moment. Otherwise, we'll move on to the next lecture. Is that okay, Darren? We'll come back to Kaitlin when she's back up and running.
Yeah, I think that sounds good. Let's just give her a minute or two.
Again, I'll remind anybody, if you have any questions, to please write them in the chat. Chat can be located at the bottom of your screen. You click on it and you address it to everyone, and it'll post on the side. And our doctors will be happy to answer relevant questions at the end of the symposium.
All right. She thinks it's going to take a few minutes to get reconnected and her talk loaded back up. So perhaps we move on. What do you think?
Yeah,
Evan?
I think that's a good idea. It's late and or early, depending on where you are. Why don't we move on to the next talk? If you're ready, Ruchi. Our next speaker is Dr. Ruchi Garg. She's the Director of Non-Invasive Imaging at Cedars-Sinai Medical Center in the Gear and Congenital Heart Program where I work. And Ruchi is going to speak to us about mixing lesions in the critical neonatal period. Ruchi?
Thank you, Evan. And Darren, I really appreciate the opportunity to participate today. I have heard much about the Mending Kids organization and have had the pleasure of being involved in some of the fundraising activities, but really look forward to participating on site when that opportunity opens itself again to outreach. I hope everybody's seeing my full screen.
Yes, looks good.
Okay, so Dr. L'Italien, despite her being interrupted partway through her talk, gave enough background that it really will help our first foray into some complex congenital heart disease. And I'm going to talk to you about some mixing lesions, complete transposition of the great arteries, and total anomalous pulmonary venous connection. And I'm really going to focus on those first initial diagnosis, stabilizing the baby, and help all of you who may not be looking at hearts every day understand a bit of the anatomy and physiology so that you can understand why these babies can present in various ways. So complete transposition of the great artery, sometimes called detransposition because the aorta occupies a rightward position in space, is where the right ventricle is connected to the aorta and the left ventricle to the pulmonary artery, such that there is basically a parallel circulation of blood flow where cyanotic blood is recirculated to the body without passing through the lungs, and oxygenated blood is recirculated to the lungs. Profound cyanosis will occur at birth if mixing doesn't occur. And so really the goal of initial management is establishing mixing. We often make the diagnosis, though not always, by fetal diagnosis. I wanted to show a picture here showing the very characteristic finding of parallel great vessels. This is the right ventricle to the aorta, which is anterior, diving straight, and this is the left ventricle to the pulmonary artery, and they have this side-by-side orientation, which helps us make that diagnosis. But the four-chamber view can be very normal. So even in our experience in the literature, up to 50% of these can be missed prenatally if not suspected by looking at those great vessels. But when it's made, the diagnosis is made postnatally, Dr. L'Italien outlined the challenge of sometimes identifying cyanosis by visual inspection of the baby. It may be very subtle, and with saturations that are in the high 80s, we may not see that clinically. So that critical congenital heart disease screen with pulse oximetry is performed on 100% of our babies in most hospitals in North America now, and does help identify babies who may have subtle cyanosis. Transposition is generally going to be more obvious. In the absence of pulse oximetry, a hyperoxia challenge test was the way in my training that we would identify these babies before we could make a definitive diagnosis. Administering 100% oxygen by a reliable method and doing arterial blood gas, the PO2 should be less than 100 and generally will be less than 50 in these babies to help have that suspicion clinically. There will be generally no overt lung disease on chest x-ray. You can see this x-ray, normal heart size, prominent thymus, but relatively normal looking lung fields. And the EKG will be equally unremarkable typically in these babies. The echo is what will clinch the diagnosis, and here is a postnatal echocardiogram looking quite similar to that fetal echo that I showed you, with the pulmonary artery here posteriorly. What we have is the probe is on the chest, and this is the right ventricle to that aorta anterior, and the left ventricle to the pulmonary artery. And when we look on apical or subcostal views, we can see that left ventricle going to the pulmonary artery with this nice bifurcation. So normally the aorta should be coming from the left ventricle and not bifurcating into branches. After we make that diagnosis, we immediately assess a few things, because these are what are so important in those critical few minutes if you have a baby who has poor mixing. And that is assessing the patent foramen ovale, evaluating the patent ductus arteriosus. We look for a VSD in all of these patients, a ventricular septal defect, because 25% of all transpositions will typically have a ventricular septal defect. And then once baby is stabilized, we want to get a good look at the coronary arteries, because there's quite a variety of abnormalities in coronary positions. The most common is shown here, but with all of these variations, that has important implication for the surgeries I'll show you, because the surgeon has to reimplant those. When you see these babies, they, unlike some of the other heart physiology, when they are cyanotic, should be respiratory managed first. Oxygen can be given freely, intubation if there's a poor respiratory effort, establishing reliable IV access, which can be done by umbilical venous catheter or peripheral IV or both. And if available, prostaglandin can be very helpful. I'll show you in this lesion that it's not necessarily as effective in some other ductal dependent lesions, but it can augment pulmonary blood flow. And then of course, having that baby as normal acidosis wise, lactate wise as possible, which sometimes cannot be normalized until you establish good mixing. So again, using my diagram, you can see here the parallel circuit, and the role of the patent ductus arteriosus is really to augment pulmonary blood flow. The flow is predominantly going to go from the aorta to the pulmonary artery. And this is helpful because there will be more blood volume that will be oxygenated, but it's really not a typical mixing lesion because there's less flow that will flow from the pulmonary to the aorta. Prostaglandin infusion is a continuous infusion and would be started immediately on this diagnosis if you have a cyanotic baby. The same physiology is somewhat present with those with a ventricular septal defect. Again, you would think there would be free mixing across that ventricular septum, but the problem is that those left ventricular subpulmonary pressures are going to be lower, and there's going to be more blood flow favoring from the cyanotic side to the pulmonary artery. Again, delivering more pulmonary blood flow, but may not provide adequate mixing. The real source of mixing that we want to achieve in these babies is atrial level shunting, where there will be a bidirectional source of pulmonary blood flow, cyanotic blood to the lungs and oxygen-rich blood, more importantly, to the aorta. This is an example of a baby we had recently who had a prenatal diagnosis and was profoundly cyanotic in the delivery room. And you can see this is that patent foramen ovale. The red blood flow is coming towards from the left atrium to the right atrium, and that little bit of blue blood is the right atrium to the left atrium. And that little, blue colored blood flow is actually oxygen-rich blood flow that the red flow is the oxygen-rich flow that needs to go to the aorta. This is a schematic showing how we achieve unrestricted atrial communication, where it's performed by balloon atrial septostomy. This can be through an umbilical or femoral vein, and a balloon tip catheter, especially designed for this purpose, is passed across the patent foramen ovale, inflated here, and then pulled back to create a tear in the septum primum. This is really important because, in fact, prior to the current era of surgical repair, and babies with unrestricted atrial septal defects, either done by this or surgical septostomy, can survive for years, not just days or weeks, but years without surgery because they have adequate mixing. They will be mildly cyanotic, but they're not at nearly the same risk as when they have a restrictive atrial septum, and then they can undergo surgery later on. This is a fluoro image of that balloon, and here's an example of how that echo looks. And we generally do it entirely echo-directed at the bedside, which allows us to perform it quite quickly if the baby is ill. In North America, typically what we will do is an arterial switch procedure as our procedure of choice in these babies. And basically we are correcting the abnormal connection of the aorta to the right ventricle to reestablish its connection to the left ventricle. The pulmonary arteries, because of the way the anatomy is, have to be draped across the ascending aorta, and you can see the suture lines here and the coronary buttons that have to be reimplanted. This only became possible in the last 20 to 25 years because of the minute size of those coronary arteries and risk for coronary ischemia if the reimplantation doesn't go perfectly. VSDs will be closed at that time if present, and that atrial septal defect that may have been created by septostomy is closed completely or partially closed. But this has to be done quite early, within 4, maybe 6 weeks, because the left ventricle, which has been subject to decreasing pressures, will start to lose its ability to handle a systemic pressure. It sort of deconditions. So in those patients, such as the ones that I mentioned, who undergo life-saving septostomy early, but may not be good candidates for arterial switch, the preceding decades before we could do arterial switch, and in some cases even today, we can do an atrial switch. This is a little bit more complex within the heart. It's basically redirecting all of that blue blood to the subpulmonary left ventricle so that it can go to the pulmonary arteries, and then the oxygen-rich blood is delivered to the aorta. And this can be done really at any point because this right ventricle is conditioned to handle that pressure, but we are left with a systemic right ventricle. There's lots of suture lines, so there are long-term, later in life, in the second, third, and fourth decade, things that we follow and we know can happen. And then the final surgery that's typically done only in those with transposition of VSD is an LV2 aortic baffle. So establishing the normal connection of the left ventricle to the aorta and right ventricle to pulmonary artery with no holes in between. So that's all for transposition. Moving quickly to our next lesion, total anomalous pulmonary venous return. This is a very heterogeneous lesion, and really what it implies is the pulmonary veins do not connect normally to the left atrium. They are going to connect by some route eventually to the right atrium. So you have full mixing of all the oxygen-rich blood back from the lungs to the right side of the heart, making a redundant trip to the lungs. There are supracardiac type, most common, infracardiac type, second, most concerning, and I'll show you why, and then intracardiac type, either to the coronary sinus or directly to the right atrium, and then mixed type happen rarely, where maybe one of the veins drains differently than the remaining. Typically there is a confluence of sorts that all the veins drain into near to the left atrium, but that's not always the case, as you can see in these schematics. And the physiology of TAPVR is really two types of physiology. One is a non-obstructed, and the second is the obstructed. The oxygen-rich blood gets to the systemic circulation in these babies through right to left shunting at the patent foramen ovale, as well as right to left shunting at the PDA until surgery happens. The infracardiac, I mentioned because it is the most likely to be obstructed. And the concern in total veins is neonatal obstruction. This is considered a surgical emergency when babies have severe obstruction to something in the pathway draining those veins to the heart. And in infracardiac, you can have ductal venosus constriction, so prostaglandins theoretically can help delay ductus venosus closure if they're available to you, or there can be mechanical obstruction as they pass through the diaphragm, this vertical vein. Supracardiac is also risk for obstruction because this vertical vein actually typically passes between the left main stem bronchus and the left pulmonary artery. But there are other types of supracardiac venous drainage, and they are less commonly obstructed. When you are obstructed, these babies look just like your severest pulmonary hypertension, respiratory distress syndrome, profound cyanosis, respiratory failure, shock due to poor cardiac output, tachypnea, and they have severe pulmonary hypertension due to the fact that those veins can't get out of the lungs, and pulmonary edema. And they, unless they have emergency surgery really have very little chance of survival. The non-obstructed veins are very different. And these ones, in contrast, may go home without a diagnosis because cyanosis may be quite subtle. And they have essentially an exaggerated atrial septal defect exam. All that shunting to the pulmonary arteries. Early congestive heart failure, progressive RV dilation, and they can survive into later childhood and sometimes reports into later adulthood. I just want to show that this snowman sign that we often see in association with supracardiac pulmonary veins, and that's because this represents that dilated confluence and vertical vein, and this is in an adult patient, and the dilated right heart border. Surgery is definitive therapy. It is establishing reconnection of those veins to the left side of the heart, to the left atrium, whether a direct anastomosis or baffling. Here's another type of baffle. There are mortality risk factors. Generally, the sicker babies are at birth, obstructed veins, younger age of operation, but as well as coexisting cardiac anomalies. This lesion can come with single ventricle physiology, with heterotaxy syndrome, and if you have a patient who's sick postoperatively with pulmonary hypertension or venous obstruction. So that was a whirlwind tour of two pretty complex heart lesions, but I'd like to thank everybody, and I'll take any questions at the end. This is from the Hike to Mend event that Mending Kids put on last year, and I'd like to thank the organizers for doing such great work.
Ruchi, thank you for a great talk on those two lesions. And as you said, we're going to save questions for the end. And what we're going to do now is we're going to go back to Dr. L'Italien. She believes it's up and running. We're going to give it one more shot to see if we can get through her good talk as well. So Kaitlin, if you want to reshare your screen and see if your talk loads, that would be a good time to do it now. Let's see if this works. All right, so we can see your slides.
You just need to unmute, Kaitlin, and then we're good.
I can't hear you.
Okay, can you hear me now?
Yep, that's great. We can hear you and we can see your slide.
Fantastic. All right, we'll call this third time's the charm. All right, so I believe that I lost y'all right around this slide where we were talking about just pulse oximeter's utility as a non-invasive and inexpensive, safe, reliable means of potentially detecting hypoxemia in a patient that is not visibly cyanotic. So in 2009, the American Heart Association and the American Academy of Pediatrics published a position statement promoting the role that pulse oximetry could play in screening newborns for critical congenital heart disease. And while I realize that this is sort of a busy slide, what I would like to direct your attention to is that, of all of these critical congenital heart disease lesions that are listed here, the vast majority of them have some degree of hypoxemia as present in the neonatal period. There is one exception, and that is a critical aortic valve stenosis. It's highly uncommon for babies with critical aortic stenosis to have hypoxemia. But pretty much every other critical congenital heart lesion may have some or most patients or all patients expected to present with hypoxemia. Additional information from this same study, in this paper, they reviewed a number of smaller studies that had been done looking at the utility of pulse oximetry screening for detection of critical congenital heart disease. And while there was some variability in the studies, some looked at pulse ox measurements on both hands and feet, others feet alone. Others had different cutoffs of what saturations would indicate a passed or a failed screen. What the combined data from all of these studies showed was that using pulse oximetry provided a reasonably sensitive and highly specific means of detecting critical congenital heart disease. So again, this was sort of highlighting in all 123,000 babies that they looked at that had some form of pulse ox screening. There was 75% sensitivity, 99.3% specificity, and the false positive rate was 0.87. When they then looked at just the patients that had screening beyond 24 hours of age, and that was 51,000 patients, the sensitivity did fall some, down to 69.6%. But the specificity rose to 99.9% with a false positive rate of just 0.035%. So really arguing that that this was a very this could potentially be a very useful test for newborn screening, and that many people had concerns that there would be high rates of false positives and there would be lots of costs by needing to do additional workup of these patients. And what it showed is if they screened a little closer to 24 hours or just beyond 24 hours, the false positive rate was very reasonable. Additionally, what these and other studies showed was that there was variability in the sensitivity of the pulse ox screen for detecting different types of congenital heart disease. So you can see all of the lesions listed here in the green box have a sensitivity of greater than 80% with a simple pulse ox screen. And you'll see these are thought of as the 7 hallmark critical congenital heart disease lesions that can be expected to reliably be picked up with pulse ox screening. So critical pulmonary stenosis, detransposition of the great arteries, hypoplastic left heart syndrome, pulmonary atresia, other types of complex single ventricles, total anomalous pulmonary venous return, and truncus arteriosus. Those that fall into the medium and the low range include critical aortic stenosis, double outlet right ventricle, triatresia, and those that would be considered low would be coarctation of the aorta, Epstein's anomaly, interrupted arch, and tetralogy of Fallot. And by low, they mean the sensitivity is less than 60%, but variable, actually, depending upon some of the specific parameters that were chosen. So I just want to take a moment to review, the data that was presented by the AHA and AAP in reviewing prior studies really suggested that pulse ox screening would provide a reasonably sensitive and highly specific screening test, and that performing the test beyond 24 hours of age seemed to be beneficial in reducing false positive results. In addition, while the test would be really good for some heart lesions, there would be some that doctors would need to continue to be aware of and have a heightened clinical suspicion for, knowing that the CCHD screen may not pick it up. All right, so implementation of screening. This is just a brief little schematic of how it's done. It really doesn't get much more simple than this. A pulse ox probe is applied to the baby's right hand, which provides a preductal saturation. Again, the blood that's going on our right subclavian artery out to our arm, preductal saturation. And then pulse ox on the baby's foot to assess a postductal saturation. And it can be on either foot. And this is an example of the original AAP protocol from 2011, and I was ready to go through this with you guys, but actually quite breaking news, just this month the AAP published updated strategies for pulse oximetry screening for CCHD. It modified the existing algorithm that's been in place in most states since 2011. The updated strategies have a goal of simplifying and improving sensitivity and decreasing time to evaluation for patients with failed screens. So this is the new and improved CCHD screen that the AAP just published this month. It is accomplished by performing an initial measurement. If the baby has a saturation of 89% or less on either the hand or the foot, they fail immediately. There's no repeating of pulse oximetry. They are referred for immediate assessment. If the baby has a pulse ox measurement of 90 to 94% in either the right hand or foot, or if there's a difference of 4 percentage points or more between the right hand and foot, they qualify for a repeat test. If the baby has right hand and foot SATs of 95 or greater, and there is a difference of less than 3 percentage points between the hand and foot, then they have an automatic pass. Okay? So for the babies that have to go for the retest, the only way they can pass is, again, if they get 95% in both the right hand and foot, with a difference of less than 3 percentage points between the upper extremity and lower extremity. And the failed exam would be if they have less than 95% in either right hand or foot, and or a difference of 4% or more. And so the main ways that this differs from the prior algorithm was that it allows one recheck in patients with SATs of 90 to 94% or a discrepancy of 4% and more. The prior iteration of this flow sheet had allowed 2 rechecks, not just one. And then the other main way in which this modification is different from the original is that the SAT has to be 95% or greater in both the right hand and foot to pass. Again, with a difference of less than 3%. Previously, it just had to be 95 or greater in one or the other with a difference of less than 3%. So what do you do with a failed CCHD screen? Obviously, examine to ensure that the baby is hemodynamically stable. Evaluate for hypoxemia. So we focused, rightly so, on CCHD during the CCHD screen, but the pulse ox screen can also pick up hypoxemia for other reasons, such as sepsis or pneumonia, which in some cases are much more common in kiddos. May need to transfer the baby to a higher level of care. If the baby's well with no obvious cause for hypoxemia, a cardiologist or neonatologist should be consulted and an echo should be performed. Newborns should not be discharged home until the underlying reason for their hypoxemia has been identified or it has resolved. And these babies will often appear normal and have no other clinical findings other than the low oxygen saturation, which is why this makes it such a good screening test. So outcomes. Since the AAP recommended and many states mandated the implementation of pulse ox screening in the early 2011. The states that mandated the screening early showed a 33% reduction in early deaths from critical congenital heart disease, which translated to 120 lives saved per year, and an additional 21% decrease in deaths from other or unspecified congenital heart disease, which corresponded to an additional 117 lives saved per year. So if we return to our well baby, we sort of press the rewind button, and at those 22 hours of life when mom is asking to go home and Jonah's exam looks well, you put a pulse ox probe on his right hand and foot and complete the CCHD screen. You're surprised to see that the reading is 84% in both the right hand and foot. An echo is completed and his diagnosis of critical pulmonary stenosis is made before he decompensates, before he goes home. Prostaglandins are started and he's transferred to a center capable of neonatal cardiac interventions. Following intervention, he's discharged home on post-op day 5. So the CCHD screen is really quite a wonderful screening test with fairly low cost and the potential for significant value in saving lives. You can see this world map, which was updated in February of 2019, showing the countries in purple, of which they now have a national recommendation for CCHD screening. Those in pink are greater than 90% are screened. Orange have multi-center programs and pilot programs. Blue have had a documented interest in adopting CCHD screen. For those of you interested in how you actually get it going, these are some wonderful resources, including Baby's First Test. There are videos to provide to families to explain CCHD screening in multiple languages. Obviously, the AAP has some fantastic resources and just some other resources for CCHD screen implementation. References, and obviously those that have questions, I'll be happy to answer them at the end. Thank you very much for your time and for bearing with me during some of these technical challenges.
Thank you, Kaitlin. Unexpected, but your talk got broken into 2, but thank you very much for that thorough description of that and showing that. I love that slide of the world map. We will save questions for the end. With a little bit of technical difficulties, we fell a little bit behind on time. the rest of us speaking, we'll do our absolute best to stay on time with our talks, and then we will have time for questions at the end. So I'd like to introduce our next speaker, Dr. Corey Stiver. She is a pediatric cardiologist and one of the colleagues of mine here at Nationwide Children's Hospital. Her focus and expertise is in non-invasive imaging from transthoracic echo to TEE, fetal and CT and MRI. And she's going to talk to us about left heart obstructive lesions and low cardiac output. Thank you, Corey. If you're able to share your screen.
Thanks, Darren, and thanks to Darren and Evan for the opportunity to speak today. So as Darren mentioned, we'll be talking about left heart obstructive lesions and how these babies present. Really, we'll just try to go through some case examples and then look at schematics and imaging, and we'll talk a little bit about the initial management and surgery for these babies. So we'll start with a case. This baby is a 9-day-old boy who was born before the era of pulse ox screening, was born at full term after an uncomplicated pregnancy. And over the past several days, the parents have noticed that he's developed poor feeding, tachypnea, and increased work of breathing. With poor feeding, he just seems to tire out and appears more gray to them. So they took him into the ED where he was noted to be afebrile, tachypnic, and had about a 30-point gradient between his upper extremity and lower extremity blood pressures. His stat was 97 in his hand. On exam, he had increased work of breathing, grunting, and appeared mottled. He had subcostal and suprasternal retractions, clear breath bounds. Normal PMI, you could feel pulses in his upper extremities, but had difficulty palpating pulses in his lower extremities, and kind of a non-specific murmur on exam. His liver was enlarged. Extremities were without edema and cyanosis, but did feel cool to touch. Chest x-ray, he did have evidence of edema and cardiomegaly, but because of the blood pressure discrepancy and some cardiomegaly on x-ray as well, the cardiology team was consulted and obtained an echocardiogram. So this is looking at what's called a parasternal long axis view. So anterior here, posterior here, you see the left atrium, mitral valve. This is the left ventricle with severely diminished systolic function. This is a ventricular septum. Here you can see this posterior malalignment VSD. You see that this conal tissue is posteriorly deviated and the LVOT aortic annulus appears small. This is the right ventricle anteriorly here, again with depressed ventricular function. Anytime you see this as your first view and you hear the story that we told you, the first thing on your mind should be the aortic arch. And then with color flow Doppler, red moving towards the probe and blue moving away, this baby does have at least mild MR in this view. You see this red and blue evidence of bidirectional shunting through the VSD. There is antegrade flow through the LVOT into the aorta. And this is just sweeping to the tricuspid valve. Again, you can see the depressed right ventricular function. And this is a 4-chamber, and you can see why babies or fetuses would have a relatively normal looking 4-chamber. You know, in fetal life, the duct would remain open, the function would not be depressed like this, but you could see why if you did not investigate the outflow tracts, and babies always have the appearance of dropout here, the inlet septum, especially in utero, you can see why a baby like this would have a normal level 1 ultrasound with the 4-chamber. But this postnatal study just showing that the biventricular function is severely depressed. And the subcostal view, looking at, again, the left ventricle, the right ventricle here with function that is depressed. So then looking at the aortic arch, this baby had severe transverse arch hypoplasia, or I should say moderate to severe transverse arch hypoplasia, high suspicion for coarctation. That transverse arch hypoplasia is almost always coexisting with infants that have coarctation of the aorta. And it's really important for surgical planning to get nice looks at that transverse aortic arch and measurements by 2D and clearly show the arch branching that helps with surgical planning as to whether this baby could have a coarctation repair through a thoracotomy on the side, or if it would have to be an aortic arch reconstruction done on bypass through a sternotomy. With color flow Doppler, hopefully it stops skipping. You can see blue flow. There's antegrade flow through the ascending aorta and through the transverse arch. You still don't really appreciate the isthmus quite yet. And this is a little bit of a modified, what we call ductal view. So the probe is around 12 o'clock, probably a little bit over rotated for this particular picture, but 12 o'clock just under the baby's left midclavicular line. This is the MPA here. This is as it plays through, LPA and RPA. And then really if we cheat with color flow Doppler, this here is the aortic isthmus, and then into the descending aorta. And then as it plays through, you can see this aliasing of flow. That's the baby's isthmus. That's all the antegrade flow they have coming from the distal transverse arch into the descending aorta. So this baby had a critical coarctation of the aorta. So management-wise, baby was intubated, admitted to the cardiac ICU, and started on prostaglandin infusion. And within a couple days, with opening of the ductus arteriosus, baby had improvement in ventricular function, and then went just a couple days later, at 16 days of age, for an aortic arch augmentation and VSD closure through a sternotomy. So coarctation of the aorta represents about 4 to 6% of congenital heart defects. You see here with this schematic, this would be representation of a juxtaductal coarctation where they exist most commonly. They can be discrete like this. They can be more long segment. As I mentioned, baby neonates that are presenting typically have associated transverse arch hypoplasia to some degree. You can have coarctations further down, things called middle aortic syndrome, or aortic coarctations, which can be really hard to see by echocardiogram, and you have to be pretty aggressive with your imaging to feel 100% comfortable ruling those out. Attributed to abnormal development of the left, fourth, and sixth arches. That's for thoracic coarctations. And there's really two theories, neither of which are 100% satisfactory. But as you can see, the ductal constriction, this picture really lends itself to the ductal constriction theory. This is right where the ductus inserts, and then the thought is that the smooth muscle cells, as they constrict in the ductus, actually migrate into the aorta and cause that pinching down. And that makes sense that some of these babies don't present until after the duct is closed. Hemodynamic theory, just the thought that there's other left-sided obstructive lesions, low flow through the left-hand side, and there's underdevelopment of the aortic arch. And that you can see if there's there's commonly associated VSDs and things that change the flow dynamics, which may lead to arch hypoplasia and coarctation. So the presence of a posterior shelf is an echo finding that we will frequently look for to really help us rule in a coarctation. That's a hallmark of coarctation of the aorta. As I mentioned, it can be discrete or a long segment. Associated lesions, really left-sided lesions, abnormal mitral valves, abnormal aortic valves, frequently bicuspid, exist in about half of patients. And then VSDs, particularly in infants. They can be membranous VSDs, muscular, or posterior malalignment like our patient had in the first case. And coarctations are associated with other vascular anomalies, abnormal branching of the aortic arch, which is important because that will dictate where your blood pressure discrepancies may be, collateral circulation, and then circulable aneurysms. So babies, as Dr. L'Italien was just talking about, they may fail their pulse oximetry screening. However, if the duct is patent, so if they've screened and the duct is closed, babies may not fail their pulse ox screen, because if they have all antegrade flow through the aorta and transverse arch, their pulse should be the same. Pulse ox should be the same in their hand as it is in their foot. So if the duct is open and there's a degree of right to left shunting, then they may fail their pulse oximetry screening. As the duct closes and the coarct becomes more critical, they may present with poor feeding, respiratory distress. They may present with a murmur that you can hear in the back. And then older patients tend to present with hypertension, upper extremity hypertension with a discrepancy in the blood pressure is higher in the arm than it is in the leg. And then also diminished lower extremity pulses, as well as a delay, being able to feel the femoral pulse behind where you feel your brachial pulse. Diagnosis for these babies, primarily made through echocardiogram. Advanced imaging, such as CT or MRI, we don't use frequently in babies. Some centers really do and really rely on it to get a nice look at the distance between the head and the neck. The branching of the aortic arch, as well as collateral circulation, and that can help surgeons in planning as well as far as how much they feel they can mobilize the arch without sacrificing important collaterals. But in neonates, you usually can delineate the anatomy fairly well by echocardiogram. We'll typically stabilize with initiation of a prostaglandin infusion, and then once ventricular function is recovered, they will go to surgery for either aortic arch augmentation or end-to-end anastomosis, based on primarily the measurements of the transverse aortic arch. Rarely in the neonate do they go for cath, but they can be palliated with a balloon angioplasty. We've done that at times. And then certainly in older children, they can have a good response to balloon angioplasty, as well as stent therapy. And Dr. Zahn and Dr. Berman can speak to that much better than I can. So this is a schematic with different types of interventions for coarctation of the aorta. So you can have a resection of the coarctation and then an end-to-end anastomosis. That's usually done by way of a thoracotomy. You can place an interposition graft. Sometimes if they feel because of collateralization, if they can't mobilize the arch very well, they'll do an interposition graft. Pouch angioplasty demonstrated here, and then a subclavian flap repair, essentially where you sacrifice the left subclavian and use that to augment the aortic arch. And that was favored a few decades ago, but now really end-to-end or aortic arch augmentation. This is an example of aortic arch augmentation that would have been done through a sternotomy, and so you can see the patch here on the underside of the aorta. Just a few more echo pictures in different patients. This is a nice example of a posterior shelf you see here. So you see the ascending aorta. There's mild hypoplasia of the transverse arch for this baby's size. And then you can see there's increased spacing between this left subclavian artery here. This is the left common carotid, almost a common brachiocephalic trunk here. Increased spacing between the left carotid and the left subclavian that gives the arch this squared off appearance, highly suggestive of a coarctation, and then that posterior shelf, which really rules in the diagnosis for this baby. This baby also had, so this baby did have an arch reconstruction from through a sternotomy. In this study, her duct was still open. You see with color flow, she does not have significant aliasing. She did not have significant blood pressure discrepancy, but really just the appearance of the aortic arch is consistent with coarctation of the aorta. This baby is a baby that had single ventricle heart disease in the form of an unbalanced AV canal defect. The ascending aorta there's a presence of a subaortic conus and a bicuspid aortic valve, so all of that raises concern for the baby to develop a coarctation. And this is a ductal view. This is a really helpful view. I alluded to it before. Really helpful view to truly show the aortic isthmus and how it inserts here into this baby's duct is wide open. It's a large duct. You can see here from the MPA. This is the ductus arteriosus into the descending aorta. And you can just see how you don't see the transverse arch much here, but you can really see the isthmus and how it takes a turn as it inserts into the ductal arch and narrows there. And then you see this continuous antegrade flow and diastole, so abnormal flow, and this baby also felt ruled in for coarctation. She was off PGE, and the duct had not gotten smaller, and so we were trying to evaluate for the coarctation in the presence of a large duct can be difficult, and so really getting a good look at the anatomy of the isthmus of the arch is helpful for that. So this next baby is a one-day-old full-term boy born after an uncomplicated pregnancy. He was transferred after a traumatic delivery with forceps for evaluation of stridor, and then developed increased work of breathing requiring intubation, had poor perfusion and of lower extremities, had a lactic acidosis and increasing creatinine. His physical exam was remarkable just for, again, a kind of a non-specific murmur, although it was heard into the back, and you could not palpate pulses in the lower extremities. So again, this baby in the long axis view has evidence of a posterior malalignment VSD. Here's the VSD, and that conal tissue deviated posteriorly, narrowing of the LVOT, the aortic valve annulus here. In these babies, this baby ended up having, in the interest of time, I'll try to move a little faster, ended up having an interrupted aortic arch, which we'll show pictures of. But after that's repaired, there's, as the saying goes, the woe is below. Once you close, you know, there's no gradient through the LVOT typically in the setting of decreased function for this baby and in the setting of this VSD. But once that VSD is closed, function's recovered, and the arch is repaired, sometimes that can unmask a subaortic obstruction. So it's really important to look at that area, as that can impact babies later in life. The four-chamber, this baby has depressed function. I prefer the parasternal long axis view that we started in to look at the LVOT, but you can see some narrowing below the aortic valve here. And then this is what the baby's abdominal aorta looked like. So highly suggestive of an aortic arch problem, and clearly a duct is not adequate at this point. So looking up at the ductal arch, so the MPA here, this is the duct. This actually is the brachiocephalic. As it's going up, you're catching the innominate vein here. But you see this restricted, or this aliased right to left shunt in the duct small. And then confirm it with spectral Doppler that this is that's a restricted right to left duct in a baby with an interrupted aortic arch. So here, this is the left subclavian coming off of the ductal arch and descending aorta here. And then you get a little bit of the first branch. And as we sweep through, you can see the interruption. So that's the first branch. There's no transverse arch here to speak of. And then the descending aorta continues through the ductal arch. So this baby had an interrupted aortic arch. Type B, which is the most common, and I'll try to show some schematics of that. So the initial management, the baby was already intubated, and so was started on a prostaglandin infusion, had been intubated for respiratory distress, which a lot of these babies will manifest as a compensation for their metabolic acidosis. This baby was started on prostaglandin, and actually this baby was initially palliated with a PDA stent and bilateral pulmonary artery bands because he had intracranial bleeds, and then when he was 6 months old, had a complete repair with VSD closure and an arch reconstruction. So these are schematics of the types of interrupted aortic arch. So you can see type A here, the interruption comes after the left subclavian artery. And it's important to note the head and neck branching, because that's where you'll get your pulse ox differential and your blood pressure differential. So here, all of the head and neck vessels and the upper extremities come off before the interruption, and then the lower extremities come off after the interruption. Here in a type B, which is the most common type of interrupted arch, you can see the right carotid and the carotids, and then the right subclavian come off before the interruption, and the left subclavian comes off after. So you may not have a pulse ox differential or a blood pressure differential if you're checking in the left arm and the left leg. To make things tricky, babies with this type of interruption, it's not unheard of for them to have an aberrant left subclavian or an aberrant right subclavian artery, and then both of your arms come off after the interruption. The right subclavian comes off the descending aorta. And so sometimes for those babies, we'll check a pulse ox in the ear. You can't really check a blood pressure from the carotids form, so checking pulse oximetry in the ear can give you a differential between the pre-interruption and post-interruption. Type C is the most rare. These are interrupted aortic arch, particularly type B, is associated with 22q11 deletion or DeGeorge syndrome. And these babies will almost invariably have a VSD. It can also be associated with AP window or truncus arteriosus. Bicuspid aortic valves are not uncommon in these babies. We talked a little bit about the arch branching, and they would present similar to a carotation as the duct is closing. These babies recently have been picked up a little bit more by pulse oximetry screening. They're obligatory right to left shunting through the ductus arteriosus. But again, if depending on which type of arch it is and where you're checking, so hopefully, checking in the right hand and the lower extremities should give you the highest sensitivity for that. So these babies we would stabilize with initiation of a prostaglandin infusion and then would require surgical repair, aortic arch augmentation, and addressing additional defects such as a VSD or AP window, as well as repair of truncus. Sometimes surgeons will do Davis case stanzel anastomosis and do a Rastelli type repair where they baffle the LVOT. This would be where they do side-to-side PA and aorta anastomosis if they can't address the subaortic narrowing, and then baffle the VSD to this, quote, neo-aorta, and then they would need an RV to PA conduit if they felt they couldn't adequately address the subaortic stenosis. And then this is a arch augmentation, just correction or surgical repair of interrupted aortic arch, and usually a patch closure of the AP window or VSD. This is another example. I just wanted to show a baby that had an AP window with an interrupted aortic arch. So aorta here, MPA here, and a large communication between the aorta and the MPA. You do see some T artifact here. It can be easy to get dropout because of how this septum is in the views that we get, but this is pretty convincing for an AP window. And then with color, you can see the shunting through the AP window. And this last, I'll get through hypoplastic left heart really quickly. I actually would like to skip this case and then we'll get down to here. So hypoplastic left heart syndrome for us frequently diagnosed prenatally because the four-chamber is typically abnormal, although that's not always the case. So this is a type of single ventricle heart defect. The left side of the heart doesn't form for some reason or another. There's theories about a restrictive foramen ovale in utero that doesn't allow the expected right to left shunting that should occur in utero for the left side to grow, or there's just underdevelopment of the LV and aorta, mitral valve abnormalities. Some babies are born with critical or start with critical PS and the left ventricle dilates, becomes poorly functioning, and then kind of involutes. So these babies frequently are prenatally diagnosed and then will typically fail pulse oximetry screening due to the right to left, the intracardiac mixing, as well as right to left shunting and the ductus arteriosus. If they're not picked up that way, they can present with poor feeding and circulatory collapse, similar to our other patients. The difference is these babies should have decreased pulses throughout. The cardiac exam, especially the auscultatory exam, can be fairly subtle despite how ill these babies can be. They may not have a significant murmur. The single S2 can be subtle. On EKG, they'll have paucity of left forces, and then these babies typically by themselves an echocardiogram. We treat with stabilization. We stabilize with PGE infusion. Babies that are prenatally diagnosed, we have that started usually within the first several hours of life. It's critical for these babies for cardiac output that they have some sort of atrial communication. At times, they may need intervention sooner in the newborn period. They can present extremely ill babies, similar to as Dr. Garg was talking about with obstructed total veins. They present with profound hypoxemia, acidosis, and those babies need intervention right away. Different surgical or hybrid approaches in the neonatal period. Norwood with a BTT shunt, so they have an aortic arch reconstruction, anastomosing the pulmonary artery with the native hypoplastic ascending aorta, and then pulmonary blood flow is provided by this shunt. There is a Sano modification, meaning an RV to PA conduit for a Norwood procedure, and most centers are performing Norwoods with BTT shunt or Sano modification. Our center typically performs hybrid procedures where a stent is placed in the ductus arteriosus and bilateral pulmonary artery bands are placed, and then the balloon septostomy is performed for the atrial septum to ensure there's an egress of blood flow from the left atrium. Those are typically reserved for babies that are higher risk, born early, or have other risks for bypass. I do not know how that writing got on my screen. Sorry about that. So This baby was prenatally diagnosed with hypoplastic left heart syndrome. You can see in the 4-chamber that there's a small left atrium, really no left ventricle to speak of, mitral atresia, aortic atresia. This is the right ventricle, tricuspid valve. This is looking at the baby's atrial septum here, and you can see shunting at the superior and inferior aspects of the ASD. So certainly an atrial septum that would need intervention before going home, but not a critical obstruction. Looking at the baby's aortic arch, this severely hypoplastic ascending aorta, the transverse arch is moderately hypoplastic. This is a baby that actually had critical AS in utero and was not a candidate for fetal intervention because he was a twin. But you can see that the left ventricle is small. There's EFE, so the ventricle started off actually dilated with poor function, and then really you could see it involute through the pregnancy. So they get this hypoplastic, hypertrophied left ventricle, evidence of endofibroelastosis. It doesn't come to apex, and so this baby also required single ventricle palliation. So apologies for the scribbling on the screen and the going over time, and we'll save our questions for the end.
Thank you, Corey, for covering all three of those left heart obstructive lesions. We will move on to our next speaker, and we'll try to catch up a little bit on time. And so I'm going to introduce Evan Zahn, who's going to speak to us on right heart obstructive lesions in the next few minutes.
Can you all see my screen, Darren?
Yes, can see it well.
Great. Well, I want to start off by saying how happy I am we get to do this symposium, but I am equally sad that we are not there in Dar es Salaam in person, and we're really missing everybody over there and hope they're doing well. When I think of right heart obstructive lesions, I think of them pretty simply. And I kind of think of them like this. This is a river. This river is flowing from the left side of your screen to the right side of your screen. And this is a time-lapse film. And you can see that these folks are building an obstruction to flow to that river. And eventually, they're going to complete that. And if you see what happens to the blood flow, if this was blood, it gets diverted. So the blood that was heading downstream is now heading somewhere else. And I think if you keep this sort of imagery in mind, right heart lesions are pretty easy to understand whenever they occur, but particularly in the neonatal period. So if we look at something, sorry, my computer's doing something a little funny, like pulmonary atresia. This is a normal heart with the blood flowing throughout the right heart out to the pulmonary arteries. And if you throw in there atresia of the pulmonary valve, which of course in a newborn is always associated with at least a patent foramen ovale, if not an atrial septal defect, what happens to blood flow is it gets diverted, right? It can no longer flow downstream. So it has to go across that patent foramen ovale and out into the systemic circulation. So to be cyanotic with an obstructive right heart lesion, you need two things. You need obstruction to pulmonary blood flow, and somewhere there has to be a right to left shunt. And that will hold true for every lesion you can think of. I'm sorry about the smallness of this. This is something with my computer, but tetralogy of Fallot, which most people are familiar with, where we have subpulmonic obstruction, sure, some blood flow can get out there to the pulmonary arteries, but depending on the degree of that obstruction, a significant amount of that blood flow is going to go through with the always present ventricular septal defect, giving you cyanosis. And as we get to more complex lesions, like let's say tricuspid atresia, where there is no tricuspid valve, blood can't enter the right heart that way, has to go across an atrial septal defect and out to the systemic circulation. Now, sure, many or most of these kids have a ventricular septal defect, and that allows a secondary source of pulmonary blood flow. But again, the cyanosis is occurring because of obstruction to pulmonary blood flow, in this case at the tricuspid valve level, and an obligatory right to left shunt at the atrial level. One of the things that all of these obstructive right heart lesions have is that they're all what we say ductal dependent. So if we look on the top at pulmonary atresia intact septum, you have to have a patent ductus arteriosus to survive that lesion after birth. Similarly, for tricuspid atresia, unless you have a very big ventricular septal defect, these patients in general really need ductus flow to maintain their pulmonary blood flow, as do patients who are symptomatic or cyanotic from tetralogy of Fallot in the newborn period. So it turns out that ductal dependency is very important. How do we diagnose these kids? Well, the hyperoxic test, we just heard a beautiful lecture from Kaitlin on, so I won't speak about that other than to say whatever Kaitlin said. That gives you a positive hyperoxic test, and it's really become one of the most valuable tools that we have when we're called for a baby who's suspected of having congenital heart disease. And in fact, we've all witnessed numerous babies now where just the simple screen picks up an asymptomatic baby. As has been mentioned, physical exam is variable. You can have a critical heart disease like transposition of the great arteries that Ruchi talked about and really have no important physical findings, no heart murmur at all. Although with the right heart obstructive lesions, things like tetralogy, pulmonary stenosis, you usually will hear a flow murmur, but that can be after a period of time because, of course, the pulmonary vascular resistance has to fall to allow that murmur to become easily audible. I find that the EKG in newborns is quite helpful as, if not a diagnostic tool, certainly as a screening tool. Almost all of the right heart obstructive lesions will have some EKG abnormalities. This is a patient who presents with critical pulmonary stenosis or pulmonary atresia tech septum, and you can see how tall the right heart forces are in V1 and V2, and the deepness of the S waves in the left chest leads. Of course, having a rightward access doesn't help you in the newborn period because that's typical. And even in tricuspid atresia, these patients can present with a very typical EKG as a newborn because you'll see that the R wave is positive in V1, but negative in AVF. And what that gives you, of course, is a northeast axis, which is always abnormal, pretty much at any age, but certainly in the newborn period. And then finally, simple tests like chest x-ray, I still believe are quite helpful. They can be variable. This is a baby with tetralogy of Fallot. You can see the very typically described sort of boot-shaped heart. There's a decrease of central pulmonary vessels. This may or may not be abnormal, but I find that with a positive newborn pulse ox screen, it's rare to have a completely normal EKG and x-ray. So also good simple tests to reaffirm your diagnosis. But of course, the money lies in echocardiography. So what would we try and do with these right heart lesions? You've heard it over and over again. But really what's changed our practice here in the United States over the last several decades is the easy availability of prostaglandin. These are ductal dependent lesions, meaning that with few exceptions, if these children don't have a reliable source of pulmonary blood flow, if their right heart is completely obstructed, they won't survive beyond the neonatal period. That goes for all the lesions we've talked about so far, depending on the severity of obstruction, and in the case of tricuspid atresia, depending on the adequacy of flow through that ventricular septal defect, which again, unless it's quite large, is not something we necessarily want to depend on. So in addition to stabilizing these babies with the initiation of prostaglandin, if it's available, there are a few other things that are typically done. Ruchi mentioned several of these. Getting central venous access, typically through an umbilical catheter, which is what's done in the United States. Many of these babies will need help maintaining cardiac output. Sometimes they need pressor support, such as dopamine, dobutamine. And what we're really trying to do is maintain their tissue oxygen delivery and their urine output as they await a more palliative or definitive procedure. Let's look at a few of the lesions simply. This is an example, a pathological specimen of pulmonary atresia intact septum. You can see the plate-like pulmonary valve up here. You can see this very thick myocardium of the right ventricle and a small right ventricular cavity, and in this baby's case, a small tricuspid valve. This is a recent baby we had, so this is an echocardiogram Ruchi did, and it's a really beautiful picture of a well-developed pulmonary valve, but you can see it's just not opening at all. There's no color flow through it. There's no regurgitation through it. It is atretic and plate-like. Some of the other key findings in a patient with pulmonary atresia and intact septum would be that you need to document that we have a patent ductus arteriosus supplying at least a temporarily reliable source of pulmonary blood flow. That's the red flow in that echocardiogram. You need an atrial communication. That right ventricle needs somewhere to send blood. And if it can't be out the pulmonary artery, then you'll see this tricuspid regurgitation, and you have to have some degree of shunting at atrial level. You see a lot of blue flow. That's right to left shunting, desaturated blood going over to the left atrium. And it's important that that atrial communication is unrestricted so that these babies can maintain cardiac output. And one other thing that's typical when you have true pulmonary atresia is this terrible right ventricular function. This is just a right ventricle, which, although reasonably well formed, apex forming, is quite abnormal. And when you compare this systolic contractility of the left ventricle seen over here and the right ventricle, which basically is just rocking, you realize how sick these babies can be. Fortunately, that almost universally gets better when you relieve the obstruction. So what we do in the US for this lesion is we start prostaglandin, we make sure the atrial septum is open. If it's not, we perform a septostomy. And we get these babies these days to the cardiac catheterization suite pretty quickly rather than the operating room. And I would say that's the majority of centers now in the US. This is what a baby like that looks like. This is a lateral angiogram, chest wall, backbone, pretty good sized right ventricle. All of this contrast here is tricuspid regurgitation filling a giant right atrium, and it's actually hard to see the right ventricular outflow tract, but if you freeze it on the right frame and or you take a catheter and put it right up under that pulmonary valve, you see that it's completely atretic. It's a good size, but it's plate-like with no blood exiting the right ventricle. So the way we treat that is using a radio frequency energy wire, which is commercially available. We place that wire across that pulmonary valve by delivering a little bit of energy. The trick with this procedure is you really have to be very centrally located on the valve. Otherwise, it's quite easy to perforate the outflow tract, and those babies do not do well. So you can see in this baby's case, we've done this through a hybrid procedure. So the diagnostic portion of the catheter came up the femoral veins from the inferior vena cava, but the therapeutic portion of the procedure we do with the heart surgeon through a small incision, and then after we perforate, are able to put in balloons to dilate that membrane. You can see we do that dilation pretty slow and alleviate any valve obstruction. So we were very happy with this baby. We were able to successfully complete this. It's just a 1 centimeter subxiphoid incision. And typically what we'll do is take the baby off prostaglandins and see how they do. So this baby, this is the same baby, but now the baby's returned to the cath lab 2 weeks later. Okay? And why is the baby back in the cath lab? The baby's back in the cath lab because every time we took the prostaglandins off, the baby would profoundly desaturate. And can everybody see why that is? Let me just freeze that. The pulmonary valve, which we've opened, is here. It's these white lines, and it's actually wide open. The problem is this baby has so much subpulmonic muscular obstruction that's become dynamic because the baby had 9 months in utero of building up that muscle, that it just isn't able to supply enough pulmonary blood flow through that little thread to maintain systemic oxygenation. So what we do in those cases is at this same catheterization, we take a look at the ductus, which you can see why the baby's blue, has a severe stenosis, but is still patent. But fortunately, it's a relatively straightforward thing to come from that same venous side and just place a little coronary stent across that ductus to maintain patency. And this is a fairly light angiogram, but hopefully you can see that now there's actually blood flow from the aorta consistently into the pulmonary arteries. So this baby should grow up, and if it follows the typical course, that muscular obstruction will regress on its own. It does so in about 80 to 90% of cases. That ductal stent will slowly fill in with tissue. And in most cases, we don't have to go back and actually plug that stent. It tends to regress on its own, and you're left with a baby with a full biventricular repair, which is why we've moved away from neonatal surgery for this lesion. Moving on briefly to tetralogy of Fallot. Tetralogy of Fallot, the definitive therapy is still surgical. That is for sure, in every country that I'm aware of. In the United States, when I was training a couple of decades ago, we started exploring neonatal tetralogy repair. And although a few centers continue to do this, we actually find that babies who undergo this operation, which entails patching the right ventricular outflow tract and closing the VSD, we find that when you perform that operation in a true neonate or young infant, while they survive, they have quite a bit of morbidity and an extended stay in the intensive care unit. So most centers have moved back to preferring to perform this operation somewhere between 4 and 6 months. So what that means is we need to find ways to palliate these babies in the newborn period. And as they say, you know, what's old is new again. So the typical operation was the Blalock-Taussig operation, the first surgery being shown here at Johns Hopkins, where they turned down the subclavian artery to supply pulmonary blood flow. Over the years, that's been modified to use a Gore-Tex tube to supply pulmonary blood flow so that we can grow these babies out to 4 to 6 months. And what's done in quite a few centers now, rather than doing a Blalock-Taussig shunt, is what we just showed, which is placing a stent into the patent ductus arteriosus, which really accomplishes the same thing. So tetralogy of Fallot can be palliated this way in the neonatal period. It supplies pulmonary blood flow for a reliable period of time, usually about 4 to 6 months. But what it doesn't do, it doesn't encourage pulmonary arterial growth. So what a lot of centers have moved towards is expanding the subpulmonic area. This is one of Ruchi's echocardiograms, and you can see, looking at this view, when you look at that yellow arrow, how much muscular obstruction there is in the subpulmonic area. That's right where the color turbulence is beginning. The pulmonary valve in this is all the way up here. So a straightforward balloon would not serve to open that up. So what we and others have moved to is stenting that region in newborns. So this is a newborn who was quite complex in that he not only had tetralogy of Fallot, but if you look at these tiny pulmonary arteries, he ended up having Alagille syndrome in addition to that. So not a healthy combination, but we knew he wouldn't do well with the neonatal repair. You can see here the significant degree of subpulmonic obstruction. Again, the pulmonary valve is over here. This big white chunk here, that's his infundibular septum causing all this subpulmonic muscular obstruction. Again, you can see we're doing this procedure, this baby weighed 1.5 kilos, so we're doing this in a hybrid fashion through a small incision, subxiphoid incision. And it's quite simple when you do this with your surgeon to place these stents. And in fact, and I know Dr. Janabi will remember this, I believe the last case I did in Dar es Salaam was a baby with pulmonary atresia intact septum, where we did a hybrid procedure to place a stent such as this. And the reason Dr. Janabi will remember it is because he was kind enough to get me an ambulance to rush me to the airport so I didn't miss my flight home that evening. And this is what you can do with a hybrid stent. This stent actually lasted this baby over 1.5 years, just this single intervention, to get him out to a size where we could rehabilitate his pulmonary arteries and perform a definitive operation. So in conclusion, I would say that think of these right heart obstructive lesions whenever you see a cyanotic newborn. Remember that cyanosis has to result from not only obstruction, but also some degree of right to left shunting. I think worldwide, we must strive to get to a place where prostaglandin is widely available in all neonatal units around the world. And that straightforward interventional hybrid techniques can be performed as either palliative or definitive therapies for many of these right heart obstructive lesions. And I know Darren's going to touch on that a bit in his talk as well. And finally, I'd just like to leave you with this. We want to wish our African family the courage, strength, and good health to get through our current situation. Thanks very much.
Thanks, Evan. That was a great talk. Evan, you are muted if you're trying to talk.
I just gave the greatest speech ever. I was just introducing Darren, who's going to give our final talk, and then we'll have a discussion. Darren's going to talk to us about neonatal critical valve stenosis, both aortic and pulmonary. Darren.
Thanks, Evan. So, as the last talk, and thanks to everybody for hanging in there, just a couple clear objectives. We're going to define what critical valve stenosis is, then delve into a case of critical aortic stenosis, how to diagnose and stabilize, and really how to treat and what those goals of treatment are. And then we'll do the same for critical pulmonary stenosis as well. So valvular stenosis, as everyone I believe knows, we tend to try and group into one of three distinct categories, whether it be mild, moderate, or severe. But beyond that is critical valve stenosis. And really the defining feature of this is that the stenosis is so significant that these patients are dependent on their ductus arteriosus remaining patent to be able to maintain appropriate circulation to the different parts of the body. And because of this definition, essentially these patients present as neonates. So if we look at critical aortic stenosis, it's more than just severe aortic stenosis. It's a patient who's unable to maintain systemic cardiac output through that aortic valve and thus is ductal dependent. Their left ventricle may be dysfunctional or the opening may be such a pinhole that their left ventricle is unable to maintain that output. The ductus has to stay open, and that leads to retrograde filling not only into the aortic arch, but that means both cerebral and coronary artery perfusion is reliant on retrograde filling. Critical AS, in terms of its diagnosis, oftentimes can be seen on a screening fetal ultrasound. The standard views include a 4-chamber view and an outflow tract view. And typically that should be able to detect important aortic stenosis and has a very good look at the changing features of what can happen to the LV during this lesion. Whether it is or is not diagnosed in fetal life, these patients will present in the newborn period, really in one of two ways. If the PDA is open and there's a suspicion for this diagnosis and there's right to left shunting at the ductus that's helping to maintain their systemic cardiac output, you're going to have a baby that looks very well appearing, relatively normal pulses. Their upper extremity and lower extremity pulse ox can be abnormal, depending on how much antegrade flow exists across the aortic valve itself. The less flow there is across the aortic valve and the more dependent they are on that ductus, they will have some degree of right to left shunting and their pulse ox may be slightly decreased. And then there's a lot of variability in the degree of the aortic stenosis murmur for the same reason. If you have a very dysfunctional left ventricle and minimal output, you may have a soft to no murmur at all across the aortic valve. And one feature that is persistent is a hyperdynamic RV impulse because we're asking the RV to do a lot of the work for this baby. This is in stark contrast to a baby with critical AS whose ductus is closing or is closed. These babies will be very ill appearing. Basically due to complete circulatory collapse. They're pale, tachycardic, tachypnic, will have very poor pulses, and oftentimes will have a gallop rhythm. For the same reasons, they may or may not have a murmur of aortic stenosis, but a persistent feature will be that RV working overtime and a hyperdynamic RV impulse. EKG can, relatively nonspecific, but there are some findings that suggest the LV is not happy. This is a patient with LVH. You can see some ST changes and flip T waves out here in the posterior leads, particularly in V6, suggesting LV strain, telling you that something is not right on the left side. Echo is a definitive diagnosis for this and is oftentimes very impressive. The parasternal long axis view, you can see here a left ventricle that's unhappy in its systolic function, very bright endocardium, oftentimes related to poor coronary perfusion in utero. You have an aortic valve that can be bicuspid and oftentimes unicuspid. And when you zoom in on the valve itself, you can see very poor mobility of the aortic valve leaflets. A couple different views, including a peristernal short axis or an apical 4-chamber to really hone in on how bad the function can be. It oftentimes is this severely depressed, and again, very bright endocardium. Associated with this can be various degrees of mitral regurgitation. And when you sweep up to the left ventricular outflow tract, you can see a very narrow jet of color of a very small jet of antegrade flow across that aortic valve. Stabilization of these patients, it's absolutely crucial. This is a theme from today's talks of maintaining ductal patency to maintain systemic perfusion. Without a patent ductus arteriosus, there's progressive end organ damage, progressive acidemia, and is invariably fatal to these neonates. With the initiation of prostaglandin E1, you have a period of hemodynamic stability, and you can try to support the left ventricle with some inotropic support. But again, your major limiting factor here is an aortic valve that's simply not opening. The treatment for these patients, while initially stabilized on prostin, because they have such poor LV systolic and very poor LV diastolic dysfunction, you don't have too much time, even though these patients are on prostaglandin. Their LA hypertension, the expected decline in their pulmonary vascular resistance after being born and their lungs starting to expand, leads to progressive pulmonary venous congestion, and you get the combination of progressive decline in their clinical status because what's happening due to LA hypertension and progressive LV dysfunction. So despite PGE for these patients, their intervention is relatively urgent. And we tend to treat that in the cath lab. The goals of that initial therapy in the cath lab is a timely balloon aortic valvuloplasty, really focusing on trying to relieve the critical degree of obstruction, not trying to be a hero and get this down to mild or moderate. You're really just trying to relieve the criticalness of the stenosis. You want to try and safely decompress that LV, and really should be thinking about this first procedure as a palliative first step for what's going to be a chronic disease. While doing that, we want to minimize any trauma to them, both to their access points, oftentimes the femoral artery. We want to minimize the regurgitation to the aortic valve, and we want to try not to injure the mitral valve during the procedure. So what does this look like for this 1-day-old who was born full term and slightly small at 2.9 kilos? There was a late prenatal diagnosis of aortic stenosis and an LV that was unhappy. Postnatally was confirmed to have critical AS and prostaglandin was started, and the echo clips that I've showed you so far are actually of this patient. So this patient came to the cath lab, and with femoral venous and femoral arterial access, it's a very limited and focused hemodynamics. You really, what we're doing is getting ourselves to the left ventricle. The catheter can come here, up the femoral vein. You can cross the foramen ovale into the left atrium, and then very gently guide that catheter into the left ventricle. Because their LVs are so dysfunctional, because there's so little flow across the aortic valve, oftentimes these patients will have little or no gradient between their LV and aorta because there's essentially no flow. That does not mean that they don't have critical AS. And then really it's about angiograms. This angiogram has to be taken quite carefully. So this is an angiographic catheter across the PFO from the femoral vein that's been curved down into the left ventricle. It's nearly apex forming LV. The LV function is quite poor. Contrast just hangs up and sits in the left ventricle. You can see contrast reaching the transverse arch and really not making it much past the ductus. The ductus is providing flow entirely to the descending aorta. And you can see the ductal flow washing out the contrast here, and that's the retrograde filling into the transverse arch. A retrograde aortogram now up from the femoral artery really highlights a normal looking aorta. You can see the limited mobility of the aortic valve leaflets. And when you freeze this, we refer to this as this negative washout jet. You can see this tiny little jet, and that's the antegrade flow coming from the left ventricle across the aortic valve. That's the effective opening of the valve right there, almost nothing. In a retrograde fashion with directional catheters, you have to get across that little opening. And when we do, it's not being a hero. We pick a balloon that's way less than 100% of the annulus dimension. Typically, aortic balloon valvuloplasties are performed with rapid pacing of the right ventricle. That does not have to be done for critical AS because the left ventricle has very poor contractility. This is the balloon being inflated across that valve annulus in an AP and a lateral view here. And when that balloon's taken out, you can repeat those angiograms. This is about as much as we want to see. The LV is squeezing already a little bit better. Contrast still hangs up here. You can see contrast more densely filling the aorta. The ductus is still open here. And really the telling picture is here on the lateral view with the retrograde aortogram. There's no aortic regurgitation, which is important. And if you look at that negative washout jet, yes, it's still small, but it's significantly bigger than when we started. So we have created more antegrade flow from that left ventricle out into that aorta. And that's really what you want to achieve with that first relatively urgent procedure. Following the procedure, this is a mainstay. You have to give these patients time. Don't push them. They oftentimes have to be left on prostaglandin for several days. We're allowing for time for that LV to start to improve in its systolic function. It can start to relax a little bit more and its diastolic properties start to improve. This is where inotropic support can help that LV, whether it's dopamine or low dose epinephrine. And over time, as you echo them, we actually should be expecting to start seeing an increased gradient across the aortic valve. That's actually a good sign. That tells you have an LV that's improving in its squeeze, and you've got some flow across that aortic valve that you didn't have before. When ready, try to trial that patient off of prostaglandin and see if the LV can do its job without the support of an open ductus. So moving on beyond critical AS into critical PS, a lot of this is fairly similar to what Dr. Zahn was talking about, pulmonary atresia with intact ventricular septum. But critical pulmonary stenosis is defined here as severe pulmonary stenosis, but in addition to that, the right ventricle is unable to provide an adequate amount of antegrade pulmonary blood flow into the pulmonary arteries. This is long-standing in utero. RVs get extraordinarily hypertrophied, very stiff, and their diastolic function is very poor. With that, you get significant shunting at the right to left across their patent foraminal valley. And really what this allows for is maintaining cardiac output at the expense of cyanosis. And if the critical PS is so significant, these patients can be profoundly cyanotic, which can be potentially lethal due to progressive acidosis. But by starting prostaglandins and opening up the ductus, that provides another source of pulmonary blood flow to maintain adequate systemic oxygenation and to stabilize these patients. So by definition, it will present in the newborn period. Again, the importance here, their cyanosis is due to right to left shunting at their atrial level. Oftentimes their pre and post ductal pulse oximetry testing, they will be equal, but equally low. The typical murmur of PS can be present depending on the amount of antegrade pulmonary blood flow. It may be softer than usual, depending on how much antegrade flow there is. And oftentimes the murmur of significant TR or a murmur of a PDA will be more prominent than their PS murmur. EKGs are relatively nonspecific, but Dr. Zahn showed a nice one of important right-sided forces, RVH here, which would suggest that there's something going on the right side. As a case example of what this looks like, this was a 3-day-old female twin that I took care of a few years ago, born at 32 weeks gestation at just under 2 kilograms. This patient had a prenatal diagnosis of severe pulmonary stenosis and normal RV function, and there was some concerns that the pulmonary valve annulus itself may not quite be big enough. Postnatally, critical PS was confirmed because of systemic saturations that were quite low, and this patient was started on prostaglandins. This is what this little baby's echo looked like. Parasternal long axis view on the left there. LV function is often normal. You can appreciate the severity of right ventricular hypertrophy and what's often referred to as sort of a effective hypoplastic RV cavity, right? There's so much hypertrophy that the space to fill the RV is really, really quite limited, and very impressive RVH here in the apical foreview. This is an off-axis apical force sweeping from the aortic valve and left ventricular outflow tract all the way to the right ventricular outflow tract. You can appreciate how dilated the MPA is here. You can see a relatively well-formed pulmonary valve. There's some mobility to the leaflets, but it's restricted. Subcostal views, again, looking at the right ventricle and looking at that outflow tract. And then with the introduction of color, you see more ductal flow coming in here with this red down to the pulmonary valve plate than you do really antegrade flow across the pulmonary valve. Couple more views by echo. It's really definitively diagnosed by echo. You can see that right ventricular outflow tract here. And sorry, that was my phone ringing. Just had to silence that. With some minimal antegrade flow across that pulmonary valve. And again, the ductal red flow coming in here, which is providing more pulmonary blood flow than there is antegrade across the pulmonary valve. You can make accurate measurements of that pulmonary valve annulus. You can look at, depending on the amount of antegrade flow, you may have significant Doppler gradients. And by spectral here, this is going to predict an RV that's going to be suprasystemic in its pressure compared to the body. It's important to look at the atrial septum in a subcostal view here. You can see the atrial septum bowing from right to left, and then the color interrogation of that is oftentimes completely right to left shunting. And this is, again, their source of why they're cyanotic. Treatment for this after being stabilized on prostaglandin is a relatively non-urgent cardiac catheterization. These patients can be quite stable on prostaglandin for a period of time, and you can plan out this procedure as it needs to be done. But a neonatal balloon pulmonary valvuloplasty is the procedure of choice, and the goal of it is to relieve that critical obstruction and safely decompress the RV while minimizing the degree of pulmonary regurgitation and avoiding injury to the tricuspid valve as well as to the right ventricular outflow tract. This is what that looks like for a typical patient in the cath lab. This can be done from the femoral vessels, accessing both the femoral vein and oftentimes just needing an arterial monitoring line. For this patient, we had our anesthesia team place it in a radial art line. And so our only access point was the right femoral vein. Very limited hemodynamics, really a look at what their cardiac output is. And then it's about coming up into the right atrium, navigating carefully across the tricuspid valve, and then comparing that RV pressure to their systemic radial arterial line. And you can see just how elevated their RV pressure is because of the severe and critical degree of pulmonary stenosis. Catheters for this, you then need a directional catheter to direct yourself across that pinhole opening, and obviously we'll take some angiograms before we cross it. This is what a typical right ventricular angiogram will look like in these patients. This is a catheter coming up from the femoral vein across the tricuspid valve, and the tip of the catheter is not down in the RV apex, but kind of in the RV body here. You can see that this is a tripartite RV. It comes all the way down to the RV apex, but you can see how hypertrophied, how the significant muscle bundles all the way down here into the apex. It's hard to really appreciate the degree of antegrade pulmonary blood flow here. There's a lot of tricuspid regurgitation all the way back, filling into the hepatic veins in the IVC. And when you stop this image here and put some arrows, you can see just that tiny little jet of antegrade pulmonary blood flow across a relatively small pulmonary valve. The work from there is to get across that small little jet. And this wire here will often send that wire across the pulmonary valve, MPA, and across the ductus and all the way down into the descending aorta. This really allows us to get this procedure done in a relatively efficacious way. This is a balloon that's been chosen and advanced across that valve. In this case, it's a 5mm balloon. You can see that big narrowing on the balloon that completely goes away as we inflate it across that tight pulmonary valve annulus. Here's a picture with a catheter after that balloon pulmonary valvuloplasty. And what you can really appreciate is just how much more antegrade flow there is across that pulmonary valve by simply tearing where those leaflets were fused together. Importantly, and Dr. Zahn's example was much more impressive than this, but you can get significant narrowing below the valve area due to that heavily hypertrophied muscle underneath that can cause obstruction below the valve. And that's represented here. When you pull your catheter across the pulmonary valve itself, you can see we're really down to mild stenosis of the valve, and you've got more stenosis between just underneath the valve and the RV apex due to that thick muscle bundle underneath there, causing significant dynamic subvalve RPS. Similarly, and for those reasons of that dynamic RV outflow tract obstruction, these patients will sometimes need prostaglandin for several days. You don't want to overly dry them out, keep them euvolemic to prevent worsening of that subvalvar obstruction. Really allow some of the RV diastolic properties to start to improve. As that happens, you'll start to gradually have less right to left shunting at the atrial level. These patients will remain cyanotic but not ductal dependent for many weeks and oftentimes months, and gradually will see their saturations improve to near normal over the months ahead. Their transthoracic echo after the procedure is really looking closely at the degree of PS and subvalvular PS, what the degree of pulmonary regurgitation the balloon has caused, following the atrial septum, and any worsening of the TR and what the RV function looks like. So in conclusion, again, critical valvular stenoses are ductal dependent lesions and will present as neonates or young infants. Critical AS, even despite prostaglandins, is really not an elective procedure. It's something that needs to be taken care of and treated within the first 24 to 48 hours of life. And the major goals of the procedure are timely decompression of that LV, and really should be thought of as a palliative procedure, as the overwhelming majority of these patients will require repeat intervention or interventions into the months and years ahead as they grow up. In contrast to that, critical PS, once stabilized on prostaglandins, becomes sort of semi-elective. You can watch them and they remain fairly stable on prostaglandin for the most part. And the major goal of that procedure, again, is an effective valvuloplasty while minimizing pulmonary regurgitation. And this intervention is oftentimes corrective, and the minority of these patients may need nothing else as they grow up into a young child and into adulthood. And with that, I'll conclude. Thank you very much.
Thank you, Darren, for that fantastic talk. I want to thank all the speakers, and we have some fantastic questions from the audience. I know it's getting late over there in Africa. We're going to keep this going until what I believe is 9:15 p.m. your time, just to get to some of these questions, which are really thoughtful. So let me begin. There's a question from Dr. Twalib Aliku. And I think this will best be handled by Ruchi. And his question is, supracardiac, what is the reason for obstruction of supracardiac total veins with a vertical vein to the innominate vein that is not apparent as a neonate, but appears later in the last half of infancy?
Thanks, Evan. It's hard for me to know without imaging, of course, but generally the supracardiac venous obstruction occurs as that vertical vein courses, if it has a course between the left pulmonary artery and the left mainstem bronchus, as I mentioned, but it may not be severe obstruction initially, as there is more pulmonary blood flow due to the pulmonary pressures dropping, more return coming through that vein. It may become more apparent because that is the primary outlet for the lung veins. So that may account for it. And I welcome any of my other co-speakers, moderators, if they have any other insight. But that's likely what's happening, and just the increasing shunt fraction over time.
Great, thanks, Ruchi. I'm going to move to a question for Corey. Corey, there's a question regarding coarctation of the aorta. It comes from Dr. Nunda. The question is how to stabilize older patients in terms of their risk of hypertension. What kind of infusion and how do you do it? And is the rate of the flow the same as for those who don't have hypertension?
Yeah, so for patients who present with coarctation, they are typically outside of the hypertension, hemodynamically stable, and older infants and even into teenagers and young adults when they're diagnosed, and their circulation has been stabilized primarily by collaterals. And so those patients we typically would not stabilize with PGE first, but hypertension is a chronic issue for them and something that can persist even after adequate intervention for the arch. As far as babies, the infusion for PGE is a continuous infusion. We typically give it through an umbilical line. If the baby's young enough to have those placed, it can be given through a peripheral IV. Continuous infusion, 0.05, usually mics per kilo per minute, up to, you can give up to 0.2 mics per kilo per minute. I think those were all the questions, right?
Great. Thank you, Corey. There's a question from Uganda, from Dr. Lubego. In Uganda, IV prostaglandin is not readily available. Can somebody talk to us about the effectiveness of oral prostaglandin? I asked Ruchi, as we were on the call, since we don't have a lot of practical experience with oral prostaglandin in the US, to see what she could dig up about this. So can you share that with us, Ruchi?
Well, I think you're seeing my share screen now. I honestly have never had any experience with oral prostaglandin, but the powers of the internet are profound. And so I did see this example of a case report. And it's also interesting because I educated myself that PGE2 is a lot cheaper than PGE1. And I'm not sure how the preparations come, but in this paper, which is from 1981, oral prostaglandin was given in children who needed prolonged opening of their PDAs because they had palliative attempts that were not successful at that time. And in fact, they used tablets that were dissolved in water and given orally. And it really seems that they were quite effective, as proven by maintaining ductal patency for a long period of time, up to 3 months in some of these infants, and an immediate decrease in saturations when the oral prostans were withheld. So I would certainly do a lot more research before considering this, but in the absence of IV prostaglandin, it sounds like this could be a viable alternative, especially if you can get the tablet form that would presumably be a lot more economical. And as we've talked about, for so many of these critical cardiac lesions, the ductal patency is really important.
Thanks, Ruchi, for finding that so quickly. And as Evan often does, he puts us on our toes sometimes to look something up quickly. There's a number of other great questions here. There's a question regarding after coarctation repair. With kids who have had neonatal coarctation repaired after presenting with coarct and severe systolic and diastolic dysfunction, post-operatively, the systolic function recovers, but remains with long-standing diastolic dysfunction. What medications do we maintain them on? I think that's a great question. Perhaps Corey or Kaitlin, I know a number of patients that we all follow together that we've seen this in. You want to comment on some of the medications that these patients will go home on for sometimes even persistent systolic dysfunction, and anything that you think may help with their diastolic dysfunction?
Sure. Typically, I wouldn't treat necessarily for presumed or apparent diastolic function. A lot of times the thing I think of most commonly to treat and be pretty aggressive about is the blood pressure, especially with fresh suture lines. And so we'll use ACE inhibitors or beta blockers for that. And for systolic dysfunction with preference, ACE inhibitors also. Once they're normotensive, or if they achieve normotension and normal systolic function, then I don't think I necessarily keep them on medications for presumed diastolic dysfunction. I don't know if Kaitlin has a different practice or anybody who's been longer.
Yeah, I would say that, I mean, there really aren't a good there really aren't a good selection of medications that we can use for diastolic dysfunction. I mean, for patients that are very sick, obviously we will sometimes use milrinone for its lusotropic properties, but diastolic dysfunction is it's a tough egg to crack. I would say most of our kiddos who have persistent hypertension status post a coarc repair, most of them are on an ACE inhibitor. Is usually sort of our go-to medication.
Thanks, thank you. And here's another great question, getting into some of the physiology and cellular levels, which now we're going to challenge Dr. Zahn with this one. This is from Stephen Nagusa. Why does hypertension persist following repair of coarctation of the aorta? And what causes cerebral aneurysms and coarctation of the aorta? 2 for 1.
Wow, that's great. I was hoping it would be an easier question. To the best of my understanding, persistent hypertension after coarctation is multifactorial. So we know from a lot of cellular bio research that's been done over the last several decades that although we may think of coarctation as a simple lesion, it's just a shelf or an obstruction, it's been elucidated that in fact in most children who grow into adults, of course, this is actually a diffuse arteriopathy. So if you look at the response to, for instance, peripheral vasodilation in patients who've had successful coarctation repair, it's not normal. It's not the same as a child who didn't have coarctation repair. So part of persistent coarctation has to do with the fact that we're just fixing the mechanical obstructive lesion, but we really don't do anything, nor do we have treatment for, as far as I know, a more diffuse arteriopathy on a cellular level. This may be in part why it is to our patients' advantage to fix coarctation as early in life as possible. We know, for instance, that if you have your coarctation fixed before 6 to 8 years of age, though that group of children have a lower incidence of long-term resistant hypertension than children who are fixed older. And the presumption is that fixing this in infancy, those children will have even a better long-term outcome in terms of hypertension. The other issue is, of course, the renin-angiotensin axis and what the kidneys see. And we know that the longer that those receptors are exposed to abnormal function. So in other words, if you're a child that doesn't get fixed till later in childhood and your renin-angiotensin system's been seeing that for so many years, those children tend to have worse long-term outcomes with hypertension, even in the setting of a widely patent aortic arch. So anybody want to add anything to that? There's a lot to that subject.
No, that was really good. That was a great explanation for it. Thanks, Evan. I'm going to send you another one if you don't mind. This is right up our alley and relates to your talk. This is from Stella Mongella Charu. Are antiplatelets, aspirin, needed after stenting the pulmonic valve in PIVS or placing a PDA stent? And if so, for how long is it needed?
Yeah, well, I think I could say this for every use of platelet inhibitors in pediatric cardiology. We don't really have data. It's one of the areas that is really lacking in our field. So what you're left with is a lot of experiential anecdotal practice. So I'll give you mine. I've been doing this about 30 years. When I put a stent in something I feel has limited blood flow or has a propensity to close, so certainly a newborn ductus qualifies under both those things, I tend to be more aggressive with antiplatelet therapy and sometimes even anticoagulation. So absolutely, for a stented PDA, much like a blay-lactosic shunt that's put in surgically, I think almost everybody in North America is putting these patients on some kind of antiplatelet therapy at a bare minimum, like aspirin and Plavix, Lovenox, and because especially if you're really ductal dependent, that would be a catastrophe at home. For other things like stenting in the right ventricular outflow tract, I truly don't know what antiplatelet therapy does there. You're carrying a significant amount of the cardiac output under a high velocity flow. I think most people's practice is to keep patients on aspirin for that, but I would be lying if I said there was any scientific data to prove that's necessary. And generally, if people do keep patients on aspirin for stents, they do it for one of two time periods. One is an arbitrary 3 to 6 months because we think stents get endothelialized by then, and one is until the next surgical intervention or a lifetime. Darren, you have a lot of experience with this. What's your practice?
Yeah, and I echo what you said, right? This is lacking clear guiding data to tell us exactly what to do. I think uniformly, so my personal approach is antiplatelet with aspirin for PDA stents. There was one attempt at a study for BT shunts that looked at was aspirin and Plavix better than just aspirin? And there was really sort of a wash. So it wasn't necessarily that being on 2 antiplatelets was better than 1. So I've extrapolated from that and not put my patients on dual antiplatelet. I tend to use aspirin. And for RVOT stents in palliative tetralogy of Fallot, just like you said, we tend to put them on a low dose aspirin, and that is for that 3 to 6 month period. And that's often bridging them to their surgery anyways. And so with the lack of data and generally well-tolerated partial doses of aspirin, it is our practice here as well.
There's an interesting question that's always kicked around at interventional meetings from Emily Chesser. Emily asks, how effective is ballooning in coarctation of aorta? It's age dependent. But certainly in the neonatal period, and this was all the rage when I was training. So that's a pretty long time ago. We thought that balloon angioplasty might replace surgical therapy for neonatal coarctation, and we learned the hard way that we were wrong. Angioplasty for neonatal coarctation, except in rare centers or rare instances in the West, is currently fairly discouraged. We did it for a while. A couple of things: the complication rate is significantly higher than it is in bigger kids, infants and children. The acute successful outcome looks pretty good actually, but the rate of recurrence is considerably higher than surgery. So nowadays, for a rare neonate who couldn't have surgery for coarctation, that patient would generally end up getting palliated in the cath lab with a stent. The problem, of course, with stents is that, they have limited size potential as of now, although people are working on stents that could be put in infants and made to adult size. But I would say that coarctation angioplasty in the newborn period has mostly fallen out of favor, and there's really a very limited role for
it. There's another interesting question from Stella about which annulus size is more reliable to determine the balloon size for both AS and PS, the one measured in the echo or in the cath lab by angiography. I'm happy to comment on this one, and Evan, you can comment as well. But I think that with excellent imagers like we have Ruchi and Corey here, and excellent imaging, you can get beautiful, accurate dimensions of both the pulmonary and aortic annulus. We will oftentimes compare that to the angiograms in the cath lab, and they will oftentimes be very, very close to each other. If there is a discrepancy between the two, then I personally look at which one imaged it better. Sometimes, depending on the catheter position and the quality of the angiogram, you may not get the highest yield of what the angiogram is sort of depicting as the annulus, and you could have a beautiful echo image and really rely on that as your annulus size. The most extreme version of that could be a patient who you can't give contrast to, a patient with renal failure or renal disease, and you're going to do something, it's not typical, but echo guided. And I would be comfortable, and I would think Evan would be comfortable as well, picking a balloon size based on that echo annulus that was measured. So I think both are highly reliable and tend to be quite close with each other. What do you think, Evan?
Yeah, I agree. In fact, on the rare occasion when the measurements are quite discrepant, we will redo everything. It doesn't make sense. So you always want to know what the echo measurements are in at least 2 planes. You always want to know what the angiographic measurements are in at least 2 planes. And if they're off by more than 10 or 20% in a baby, something's wrong with somebody's calibration. So I think it's a good point, because they really do tend to correlate. I would only add to what Darren said in terms of the caveat with the aortic valve. It's really critical not to oversize, because aortic insufficiency in the newborn period can be a much bigger problem than mild to moderate residual aortic stenosis. So if in doubt about our measurements on the aortic side, we will always go small. Go with the smaller measurement, pick the balloon to the smaller measurement, because we don't want to oversize. And you can always go bigger slowly in 0.5 millimeter increments. But yeah, for the most part, I think they correlate. Hala has asked a question about, have you tried drug-eluting stents for PDA? And it's a really timely question. There's a lot of debate about this in the interventional field. It's been interesting to watch what's happened with drug-eluting stents. Initially, pediatric cardiologists were very fearful of these because we didn't know the pharmacokinetics and how that would affect, particularly, they're made for adults. So what kind of dose are you giving to a 3-kilo neonate, and could it be harmful? So there are some studies ongoing and some that have been published. A lot of this work is coming out of Texas Children's in Houston. For my own practice, and this is probably just because I was doing this before drug-eluting stents, I have tended to stick with bare metal non-drug-eluting stents. But I can tell you that the people who are looking at this have shown some very compelling data that in certain settings, and PDA stenting may be one of them, that drug-eluting stents will fare better in terms of long-term patency and less buildup within the lumen. And I'd be curious as to what your guys' practice is at Nationwide.
So I agree. Some of the interesting data, particularly coming out of Texas from the U.S. side, is supporting just what you said. We have not shifted over for PDA stenting. There are the tough to handle pulmonary vein stenosis that has required stenting. We have moved to drug-eluting stents in that scenario. I don't think we're too far off from making that jump to a drug-eluting stent for PDAs as well. But for now, we have been using the bare metals.
Okay, I think we probably have time for one or two more questions, and there are a lot of them. You guys are asking really, really good questions. Let's see, so many to pick from. I'm going to go with this one. How about this one? For pulmonary atresia-intact septum, in the absence of radiofrequency for puncture of a discrete membrane, what other hardware would you advise? Well, it turns out that I'm old enough to have been doing this since before we had radio frequency. In fact, that device was really spearheaded and invented by my co-fellow, Dave Nickenen, during our training. So as Dave was trying to figure out how to do that, we didn't have anything but the stiff end of guide wires and occasionally a needle. You can do it that way. The problem, so mostly what we use is the stiff end of a coronary guide wire that you bend into a position that looks like the right ventricular outflow tract. The problem is with that as you're making the turn through the right heart, it gets very distorted, and you, more often than not, that wire ends up pointing anteriorly, and you put the children at risk for perforation. I did learn a lot about cardiac perforation during that time period. And let me tell you, those babies get very sick very quickly, and you have to be ready to drain that pericardium. I will say that with the advent of the hybrid technique, which gives you a much straighter shot at the pulmonary valve, the stiff end of a guide wire is really very doable. In fact, when we did our case in Dar es Salaam, that's exactly what we used. Our surgeon put us just below the pulmonary valve in a perfect angle, and we pushed the stiff end of a guide wire through, and we had a successful valvuloplasty. So that is definitely a viable technique. Darren, comments?
Yeah, everything you said is spot on, and I'll add to that. With the technological advances of some new wires, there are some interesting wires that may play a role in being able to help decompress or puncture the pulmonary valve without having to deliver radiofrequency energy. So CTO wires, or complete total occlusion wires, are really interesting wires that are designed to go through chronic thrombus, right? So they're relatively soft tipped until they hit something hard. And then depending on the weighted tip of the wire, which varies quite a bit, they can turn almost into a spear. And so what that wire, and we've done this in a handful of times and are starting to look at whether or not this is going to make the procedure even safer, is the advantage of that wire is you can overcome exactly what Dr. Zahn was saying. You get that wire to the pulmonary valve plate with it acting nice and soft and floppy without distorting where you're pointing on the pulmonary valve. And then when you're ready and you push that CTO wire against the pulmonary valve plate, it turns into a spear and has the ability to push through and make a small opening. And so that is one technique that we've started to go to first to see if we can get across the valve safely before reverting to radiofrequency perforation. So if you have access to the wire, that'd be something to consider.
Great points, and I know you're looking into this, and we're excited to see what should come out of it. I think we have time there's a few questions on transposition that I think we'll send over to Ruchi and try and finish in the next few minutes. I just want to remind everybody that Mending Kids will email all the participants the presentations and a link to YouTube when this is available. And if there are any further questions beyond the symposium, please address them to hello@mendingkids.org. It's in the chat session here. We also are planning future symposiums probably within the next month or two, and we'll email all of you and let you know if, what that is to see if that's of interest to you. In that email, Mending Kids is also going to send out a survey to see what was good, what could be better about this type of forum to get your feedback and input. Ruchi, would you take the last few transposition questions? Maybe you can read them and answer them at the same time.
Sure, I'm very happy to clarify a few things as much as I can. So a few questions are really relating to timing of repair if it needs to be delayed. And you know, I mentioned 4 to 6 weeks as the age we think of for really trying to get our repairs in because of the deconditioning of the left ventricle as the pulmonary pressures fall. So one question came up about pulmonary hypertension and later repair. In fact, that can be protective. So I've had patients I've cared for who are premature, who have some pulmonary hypertension, and that persistent high pressure in the right ventricle, the pulmonary arteries maintains left ventricular conditioning. So in fact, it can be protective to allow for a successful arterial switch later on, but of course would need to be addressed for whatever the underlying reason is post-operatively. So that sort of answers the pulmonary hypertension question very quickly. And then there was a question about how late an arterial switch can be done. And that is a little more of a subtle answer. Under 4 weeks, I think that's without really much concern. It's the 1 month to 3 month age range. And I have, again, a little article that I can share with you. I think this is the correct one here. And this talks about arterial switch between 1 month, essentially to 3 months of age. Are you seeing this arterial switch beyond 1 month article? Evan?
Yes.
Okay, fantastic. So I think one of the take-home messages from this is that it can be performed, arterial switch operation subsequently. But in fact, paradoxically, in this, as well as another article I'm going to share with you, the mortality seemed to trend higher for those patients who actually did have left ventricular training prior to the arterial switch operation. And so the consideration of doing that where you might assume it to be protective may be of an issue. And I think this article in particular is worth reviewing because its outcomes overall in many nations for transposition of the great arteries. So this includes, sorry, I want to show the map that they have in this article, which is great, which, sorry, I think the images are separate. Okay, in any case, in this article, the arterial switch operation, training of the left ventricle, where it's a 2-stage arterial switch operation by putting a pulmonary artery band, as well as atrial switch was reviewed. And interestingly, they showed surgical outcomes of 85% survival, which with 15% mortality, that's much greater than what we would generally prefer of less than 3% when we are quoting to families, but that outcomes can be quite good. They also found a worse outcome with the 2-stage repairs, the patients who had arterial banding, pulmonary artery banding before arterial switch, and that was greater than those even who had an atrial switch operation. The other comment is that the septostomy procedure that I described was quite infrequent. I would posit that our septostomy is more like 84% rather than 16% incidence. And there have been some suggestion that immediate saturations can predict whether you need an atrial septostomy. So I think that just shows whether the babies are a little more stable to begin with and can wait until their subsequent intervention. So the bottom line, I would say under 4 weeks for sure, arterial switch is possible. 4 weeks to 3 months, consideration of how that left ventricle looks. If there's a VSD, they certainly can have arterial switch if that's being considered rather than Rastelli. Pulmonary hypertension, more likely they can have it. So all those things have to be considered. And often here we will even consider an MRI to look at the left ventricular mass to be sure that it is adequate to tolerate systemic pressures.
Great, thank you for that comprehensive answer. I want to again thank first and foremost Mending Kids for putting this all together. A lot of hard work went into this. Christina, Chawe, Isabel, of course, and the whole team. A special thanks and good wishes to our dear friends, Dr. Nais, Dr. Janabi. I see a lot of the team on from JKCI, and we wish you all well, as with all of our African colleagues. And special thanks to all of the speakers and my co-organizer, Dr. Berman, who really did the lion's share of all the work and heavy lifting, which is why he gets to have the last word today.
Well, thanks, Evan. You said it best. There's not too much more to add. We have to thank everybody for their hard work and dedication to this, from the Mending Kids group and from the group in Tanzania. This has been a fantastic introduction for me to all of you. I look forward to continued collaboration together, and not soon enough, hoping to get to meet in person and spending more and more enjoyable time together. So I've really enjoyed myself. Thank you to all the speakers as well. And I look forward to more of these in the near future.
Any parting words, Isabel?
Yes, I mean, I'm excited. Everyone here today took place in our first virtual symposium. And as mentioned, we hope to offer more in the very near future. If you need to reach us for whatever reason, please do so by writing to us at hello@mendingkids.org. We'll be posting this symposium on YouTube very shortly. And again, we will communicate with all of you the presentations from the doctors, YouTube links, and just follow us on social media if you don't get our emails, so that you can stay in connection with us. And we'll do our best to provide as many exchanges of knowledge as we can in the future to try and stay connected. And together we're Mending Kids. So thank you very much. Asante sana.